Welcome to Season 2 of the Lipedema podcast, hosted by Shayan and Tiana. Our aim is to make noise around lipedema and educate as many people as we can about this disease.
Our guest list contains professionals who work in the field and women who live with lipedema. Thank you for joining us. Professor Ramin Shayan is a distinguished academic plastic and reconstructive surgeon affiliated with several private hospitals in New South Wales and Victoria. In addition to his clinical practice, he is the co-head of the Lymphatic Biology Lab and director of the O'Brien Institute Department. Specializing in microsurgery, his research focuses on lipedema, lymphedema, radiation injury, and fat grafting. With Shelley and Tiana, and today we are joined by special guest Ramin Shayan. Ramin, it is such a pleasure to have you. Thank you for joining us.
Thank you for asking me on.
Oh, it's a pleasure. Now, I want to get straight into it because we have so much to ask you. And I guess the most important question for us is to start from the beginning. How did you come to learn of lipedema?
Well, it was actually quite an indirect journey. Between my basic surgery training and advanced surgery training in plastic surgery, I took 3 years out and did a molecular biology PhD in, of all things, lymphatics. So I lived and breathed lymphatic biology in cancer metastasis and lymphedema, and we were trying to unlock some of the secrets as to how you can stop cancer spreading and then how you can also make the lymphatics grow and regenerate when you've had a treatment that either targets or obliterates the lymphatic vessels. So I kind of went into my plastic surgery training for the next 5 or 6 years and then into my practice with that filter on. And partway through my training, a plastic surgeon here in Melbourne called Professor Wayne Morrison, who used to run the O'Brien Institute, asked me if I'd like to start a lab there. So I started a lymphatic biology lab there in 2013. And a lot of what I was doing was lymphatics in the lab, lymphatics papers, conferences, and microsurgery. So microsurgery to connect lymphatics into veins called lymphaticovenous anastomoses, lymph node transfers, and then liposuction and tissue excision for more chronic fibrosed cases of lymphedema. And so that was 2013. And around 2014, 15, I started being referred to these patients who had clearly a pattern that was very distinct, very repeatable, and very recognizable, because you could actually see these patients walking down the street and you would recognize them from 200, 300 meters away. And these patients who were coming in were being referred by lymphedema clinics for their lymphedema, but they also had this leg shape. And essentially the short answer is I learned from the patients. There were no resources, there were no podcasts, there were no online reputable journals, there were no patient groups and patient cohorts back then. And it was around that time we were recruiting Tara Carnesis, my wife, who you're going to interview, into the lab. And I said to her, look, I think that, this disease really needs us to look at it, because I'm looking everywhere around the place. There's nothing there. So 2014, we started raising some funding for our Lipoedema lab at the O'Brien Institute. And we started that lab really fully functioning once it raised money, probably early 2015. And we started researching it. And as the journey unfolded, of course, I started seeing more and more patients. I also noticed that the way that I saw back in 2013, 14, the treatment being done didn't make a lot of sense to me. And there were some people who came trying to sell some machines and some equipment, and I asked them the questions, and the more I dug, the less it made sense. So I decided to sort of throw out the rule book and try and go back from square one and, drive a scientific-based approach to it that would understand the pathological processes that were happening in lipedema, and to really throw out the dogma, what we were told. I certainly realized that a lot of these patients had problems with lymphedema, whether it was primary or secondary, didn't know. The inheritance patterns were very interesting, but they weren't immediately clear when you looked at the family and the inheritance pattern. So there was a lot more going on. And so when I started sort of devising the way that I have come to end up treating patients now, which is liposuction with, in the appropriate patients, often tissue excision, this gave us the opportunity to have tissue that would be able to slot into our lab research program. And so together with Tara, then when I became the director of the Institute, we started to actually put a lot of time, effort, money, people into this program. And, as you know, research is a slow game. So I think in 2022, end of 21, beginning of 22, we published a paper in which we identified this sort of stem cell population and a gene or a dysregulation of this in the BUB1 gene that was leading to the adipose growth and hypertrophy. And that was really 5 years of work, 6 years of work that had gone into that. And that's the sort of life cycle, unfortunately, with research. Now, when I look at my career now, after having done, several thousand cases of lipedema, and you're always learning, just like I learned from those first patients who I saw what lipedema actually was, you're learning from every operation you do and how to do it better and how to get better results, better aesthetic results, functional results, and to help them understand not what you, the surgeon, thinks is what they need, but what they tell you they need as the patient. So it's very much a bespoke, very much a patient-driven thing. That really, as I was going through it, I sort of started to get the feeling of how big this problem is, how one can play a small part. And I sort of decided then to dedicate my life to this, and Tara and I have been doing that as our predominant activity ever since. But, when I look at my career, I was saying to you offline before, Tiana, I look at my career and I'm, if I'm 40, mid-40s, late 40s, and I look at doing this work and other physical reasons, it's pretty taxing work physically. You're looking at doing it for 20 more years. That might be, 3,000 or 4,000 patients you can actually treat, whereas that's not enough. You're not solving the problem. Whereas with the prospect of research, the exciting thing is the tissues we feed into it, the research program we have there, which you'll hear about from Tara later on, enables us to really try and unlock some secret that's potentially might help with identifying, diagnosing the disease, diagnosing who might get it before they have it, which would be really exciting. And the other side of it is then, potentially treating or curing the disease. Along this journey at the same time, back in 2014, one of my first patients was Nola Young, who's the now obviously well-recognised and, iconic initial president of the Lipoedema Australia. Then it was called LAS. And along with Nola, she taught me a lot. They supported us financially. We spoke at their talks. We, raised awareness together. In fact, we recruited from their cohort of patients our first genetic studies. And excitingly, I don't know if I can talk about it yet, but Tara will tell you potentially that we have just had accepted a paper. We're just going through the proofs of one of the genetic studies that we actually presented online. I don't know if you saw this, the Stanford talk on, Saturday morning, our time, Friday, Stanford time. Stanley Roxon hosts this annual Stanford virtual seminar on lymphatic diseases, and Tara and I gave the Lipoedema talks on it. And she actually announced that, we have this great understanding of the fact that probably initially the genetics are much more complicated than we think of lipedema. There's no one gene, and also that there are far more intricate parts to it that are involved, such as inflammation, the connective tissue component or so-called extracellular matrix, as well as the fat cells and as well as the lymphatics. So there's this complex interplay happening on a scientific sense that's driving this disease, and each different individual is coming at it from a different angle. So as the clinician, this is really important to understand, because I see and I characterize it as it's one big vicious cycle, right? So wherever you tap it, wherever you come in, whether you got it at puberty and then you had mobility problems, which then led to inability to participate in active exercise, and so forth, and you might have then, got secondary obesity, which might have led to osteoarthritis, more pain, can't mobilize, inflammation in the legs, diabetes, and so it goes, right? This huge complex web of interconnecting diseases, all of which the root cause is the lipedema that started off. Now, the reality is, for such a complex thing, you have to actually find, of these multiple vicious cycles, the mini cycles that are at play in that individual. And so you then get that sort of approach that you take for that patient. Where do you start to unpick that complex web of problems? Well, you have to then tailor that approach to the patient. Maybe inflammation and pain is the main thing. Maybe the secondary obesity is the main thing. Maybe lymphedema is the main thing. Maybe the ascetics not being able to participate in sporting events. Who knows what it is? But there's so much. And then on top of that, add in the psychological part of the fat shaming, the stigmatization, the cultural misappropriation of the female form, and so on. Those things are so complex that you need to actually sit right back, and the only way to do it is to break it down into a series of small problems and just start chipping away at the chinks in the armor, if you like. And so that's really how the whole thing evolved for me. And I love the surgery. I love what you can do for patients. It definitely speaks to the sort of the principles of plastic surgery, because in plastic surgery we talk about form and function, and this is a disease in which form and function are inextricably linked, in that part of the function of the human body is the form of the human body as well. They're inseparable. You can't say, okay, this is an aesthetic problem, we shouldn't fund it, or it's no such thing. If you can't feel integrated into society, feel comfortable, and not feel self-conscious, how are you going to hold down a job? How are you going to go for a job interview? How are you going to raise a family and turn up to school functions? How are you going to participate in sporting activities, feel sufficiently confident to find a partner, or to go traveling, or whatever it is? You cannot separate form and function. And so this is the problem with our system, is that it's characterized as being an aesthetic problem. But, okay, on the superficial level, you might say that some patients have the aesthetic thing front of mind, but actually it speaks to the ability for those patients to get the best out of themselves, to be their best selves, if you like, and to actually let out the person within. And that's not aesthetic. That's a human right, to be able to let everyone do that. So I guess that's what the philosophy is that drives what we do. And the clinical and the research are inseparable. They're part of the same thing. I mean, the research drives the practice of how we approach the patients clinically, how we approach the surgery, how we provide their aftercare, why it takes a long time to prepare patients often, and so forth. So that's hopefully a very long-winded way around the question of how we got involved. But it is also not only how we got involved, it's how we now inhabit that space and try and contribute to that space.
Yeah, thank you. So I've just written down 4 more questions based on everything that you've just said, because my mind is blown. So I wanted to step back to when you spoke about, your initial presentations of lipedema and the dogma and the things that you were told. Yes. Was that when you're talking about aesthetics and just being obese? Is that sort of the dogma that you were hearing? What was happening back then?
I guess on 2 levels. I found that there were patients, and to my embarrassment, every single week I hear patients come in and say that colleagues of mine, medical professionals and others, said, you're eating too much, you're fat, you're lazy, go and lose weight. Even today, I mean, this is now 12 years down the track from that time. I'm talking also, so that's thankfully, I think it is reducing, but the fact that it still even exists it's kind of heartbreaking and very, very disappointing. But we just have to persist with education. So some of the things that we've done with that are presenting at the College of GPs. Anita Manas is in charge of education at the College of GPs, fantastic GP, very, very switched on, about lipedema, huge advocate. And so we've presented a few times some of the basic science of education around what the diagnosis should be. And I think it's improving, but even if it's improving and there's still, a doctor out there who's saying those things to a patient, that's not good enough. We need to strive for universal education, just as you would expect a doctor who hears a patient come in saying, I've got chest pain, to suspect a cardiac condition and do the appropriate things. You would expect patients with lymphedema to get appropriate compression and so forth, and also with lipedema to have the right pathways. The dogma also in terms of treatment was that, I said to people, it doesn't make sense to me pumping a huge amount of water in the water-assisted technique, for example, into a leg when I've just done the lymphatic study and found that this leg is actually overburdened with fluid. Right? It's already, this leg has a traffic jam. So if you've got a consultant down from Sydney to Melbourne to say, let's solve this traffic problem, and they say, yeah, cool, my solution is I'm going to put another 10,000 cars on the road, you wouldn't pay their consultancy fee, you'd have them on the first plane home. So to me, it just didn't make sense. If you've got a leg that's borderline and the patient's telling you, I get swelling, I get lymphedema, why would you pump more fluid in to this leg, right? You can get the adrenaline in, you can get the local in under lower volumes of fluid. And if there are some patients who need that, why are we doing it for every patient without looking at their physiology first to understand a bit more about what makes that patient's disease processes tick and integrate? That was really the dogma. And then the research, I guess the third level of dogma was the way that the research was viewed. People thinking it's just obesity fat. Well, the research that Tara will probably talk to you about a bit later is that, in fact, it couldn't be further from the truth. It almost shouldn't be called fat, the tissue in lipedema. And the fact that it's been called fat has been at the heart of some of those misnomers, misunderstanding, miseducation. It's actually a different tissue. It feels different. It looks different. It behaves differently. It grows differently. We know that when patients doing the completely appropriate measures such as diet, exercise. Now we have, of course, things like Ozempic and Mounjaro and other weight loss drugs, even bariatric surgery, and they don't lose weight. How can you say that that is the same tissue? It can't be the same tissue. It's physiologically distinct. And so if you download our paper or some of the work we've done, the physiology of those cells that makes up lipedema is completely different to adipose disease, adipose tissue from obesity. It's totally, and we use that as the control or the comparison tissue. So it's completely different. And the fact that people still tell people they're fat and that's fat, it drives me crazy. I get pretty annoyed by it. But so those I guess those three levels were the dogma that I was referring to. At the beginning, they didn't make sense, and one by one, we've tried to disprove them and to challenge them, and hopefully, the contribution that we make through combining the science, the surgery, the clinical understanding, and also the advocacy and working together with patient groups. The thing I love about this disease more than anything is the fact that this is a disease that has exemplified how patients can take their destiny by the scruff of the neck and move it along and shift the dial. And you guys, for example, make a podcast, Lipoedema Australia, all these great people we've met along the journey who have helped us understand the disease better, helped us recruit, helped us to, advocate more effectively. That's probably the most exciting part. How many other diseases can one name where there's been such a amazing cohesive effort, and the professionalism that comes with it is astounding. A patient cohort with so much willpower, and that's why. And we look at the Lipedema Foundation in the States as well. We were lucky enough to get a grant there from the Lipedema Foundation, and to do some more work, and participating in the first Congress over there in Germany last year in Potsdam. It was just super exciting to see the patient advocates who came and spoke. In between every session, they had the science session or the clinical session, and then they had the patient advocates opening with a talk at each session from a different country. And it was just amazing. Not even necessarily the content, the fact that they were there and that there's such a heavy involvement at the organisational level, the funding level, it's fantastic. Lipedema Australia has provided funding to us for research. They've helped us recruit patients. They've helped us to spread, messages about what we think the research direction should be and how people can help. And I don't know any other disease where that happens.
Fascinating. That's really fascinating. Now, you mentioned before that there is a prominent, you're finding a prominence of lymphedema in lipedema patients. Is that fairly standard for the patient cohort that you've seen? How does that interplay with each other?
Yeah, I mean, that's one of the key questions we're looking at the moment. One of the studies we have which has been a couple of years in the making, has been to take some family cohorts of patients that have been obviously my patients, but usually it's been one or two members of that cohort that have been my patient group. They are often, presenting with, say, one member has lymphedema, one doesn't, but we're looking at what genes are there across the cohorts. We've got a couple of twins, which are really educational for us from the genetic profile. So definitely where we sit at the moment is in our lab, we don't think that it's necessarily, people used to say that the lymphatics were the cause of lipedema. I don't know that we agree with that. It could be secondary to the physical fibrosis in the tissues. It could be that there is a sub-cohort that has primary lymphedema as well within that cohort, and there's an interplay with the genetics. I think the jury's out. We hope to illuminate our field a little bit by having having some data on this in the next probably six to 9 months. But I think the bottom line is it's a part of the disease. Is it primary or secondary? We don't know. Probably some genetic correspondence, but it's not a magic bullet single gene here. Nevertheless, you have to consider the lymphedema in the treatment, because in patients who are just borderline and at risk, the risk is that you give them full-blown lymphedema or create a worse problem in the lymphatics, and that's something that clinicians have to watch out for. Definitely in the preparation for surgery, managing the lymphatic system is a key part in all of our patients. Certainly all of the patients that I operate on, yeah.
I want to I want to just ask you, so you said that all of this research that you've been doing is influencing how you approach your patients, and it can be different for, like, it can vary from lipedema patient to lipedema patient.
That's right.
Lipedema patient. Can you just expand on that a little bit? Like how you make that determination, face value, give us the cliff notes.
Yeah, I guess, so I essentially start off, assess each patient, do a sort of a biopsychosocial model of what the patient looks like. There's an interplay between, I think it's really important to understand how they have grown up with their condition, what society has fed back to influence their sort of disease experience, and then how that has related to what we can do. For example, if you've had someone who has been told in their household or in school that they're obese, lose weight, and they've struggled and haven't been able to, they've been fat shamed, and then by the time I've seen them, maybe they have gained some secondary obesity fat, which we need to then help them with. Sometimes that is a fraught discussion. It is very difficult. There's triggering involved and so on. So how do you then discuss that with that patient? There's a whole vernacular that one must employ. There's a whole range of colleagues and specialists that one must bring in and really bring that patient on that journey and unpick all those decades of inappropriate fat shaming and so on, to understand that, okay, we're dealing with populations of cells. Let's break it down to the biology. In you, your leg consists of this population of pathological adipose tissue, which is the lipedema. Also, on top of that, you have had some swelling on top, which has then led to fibrosed pathological lymphedema adipose tissue. And you've got, of course, the third type of fat, which is the obesity type of fat. Now, we must individually tease those apart and try and remedy each one of those in turn. How do we do that? And it's about forming a therapeutic relationship or a therapeutic partnership, I guess, with the patient to understand what that historical fact is that led us to where we are now, the patient you see in front of you, and give clues to how you might unpick those interplays one by one. But also, what is their priority? You might have a patient who comes in and they are like, well, you know what, it's the pain for me, or it's the fact that I can't wear boots, I can't take my daughter horse riding, or it might be the fact that I've never been able to go to the beach with, shorts on, or whatever it is. And the most important thing is to listen to the patient. And from that, overlaying what the actual disease profile, and I say the profile because there are multiple different diseases there working together. What is the disease profile that is contributing to what that patient dislikes? And that's how you one by one tease apart. And it's about having a tailored sort of approach to things. And early on, there were patients who weren't necessarily on board with that. They were so desperate due to the years and years of frustration to get something done sooner. And it's taken a couple of years to help, I guess, spread that message of why does it take a year, sometimes 2 years, to prepare for surgery. This is big surgery. And unfortunately, in some places it's been sold as like going in for some lunchtime Botox and off you go and everything's fine. The risks haven't been appropriately represented. The fact that you can have other sequelae and other diseases that result. Some things get worse, some things get better. Hospital has a risk of, infection, DVTs, general anesthesia, local anesthesia. Not enough attention's being placed on this, and oftentimes people have rushed into it. And I think now that the full cycle has come through, I would say conservatively probably 30%, 40% of patients I see are people who've rushed into something and then come back and go, well, this didn't actually address what I was trying to do. So you then have to start again and patiently go through the whole process and really start building that rapport, the trust, and building the approach that you take for that patient. But the positive part about that is I think people are now understanding through the great work that yourselves and others are doing in publicising the way that you need to approach this. Take it seriously. Surgery is not a joke. You don't just jump into it willy-nilly. And it has to be the right person doing it. It has to be the right approach for you. The priorities have to be aligned. And then and only then can you hope to get a result that makes both the patient and the surgeon satisfied with what you've done. There's a whole back team. There's a whole backroom team. The therapists, nutritionalists, dietitians, psychiatrists, psychologists, or bariatric surgeons, rheumatologists, orthopedic surgeons. There's all these people we potentially have to involve. And not everyone for every patient, but for every patient, I guarantee there's at least one or two of those multidisciplinary team members that need to be involved in some shape or form. And now I think that message is getting through. But at the beginning, people wouldn't wait. They wanted today. But I used to tell them, that this has taken a whole lifetime to get to this point. You can't just flick a switch, right? It's going to take at least a number of months to years to reverse that. And your first shot is your best shot. If you do it right the first time, that's the chance of getting it right and not needing multiple surgeries or a whole start again process. And hopefully that message is getting through.
Ramin, I am one of those annoying people if I was to come into your office as your patient and be like, I want it tomorrow. I'm ready. Just make it happen. I probably wouldn't be the best
understandable.
patient.
No, it's understandable. And that's because the moment there is a big glimmer of hope, of course, people suddenly do get their hopes up. And that with the privilege of doing the job that we do, that I love, comes with it great responsibility. And that responsibility is, the adage of the Hippocratic Oath, which is first do no harm, right? You're better off doing nothing than harming someone or to sending them backwards. And look, I mean, no one's perfect. I'm not magic. No one's magic, right? It's about just getting the best improvement you can for that patient, and hopefully they walk away, walk being the underlined word, walk away really happy and satisfied that they've, because look, as you know, it is time consuming, there's risk involved, there's cost involved, there's all of family's resources, travel, whatever it might be, and you want to do it right, do it once. You don't want to be sitting there doing, sort of piecemeal stuff and changing directions. You just have to get it right. And a lot of the stuff can be done, I call it off the ball work, right? A lot of the stuff that can be done is before you even get to the surgeon, with the GP, the therapist, the resources you have. You can do a lot of the management of the lymphatic side of it, the pain side of it, the diet, the keto, the weight gain, the non-lipedema weight gain. All of that stuff you can actually manage really easily and really, in a not risk-free way, but in a low-risk way. And I think for people, rather than seeing it as I'm waiting for surgery, it should be that I started my active management, and at some point in that journey, there is a point that surgery is involved, but it's not the be all and end all. And also, I am a part of that team too as the patient. I must also have a responsibility. I need to do a part of it. I need to, be involved in decisions and understand. I also have to understand what the disease is manifesting like in me. And that's really important. I think that's where the community has really, in a way, the actual patient cohort and community has done more growth, improvement, education, and obtaining understanding than possibly the medical profession has in a way. But the community has really started to really embrace those concepts and understood that if you want a real solution, and mind you, surgery is not a cure. The cure will be when we find the gene or genes and we treat them through molecular therapies, hopefully what Tara will talk to you about. That's a cure. Surgery is just managing the symptoms, improving, yes, if done correctly, a quality of life. But it's really about, I sort of sound like I'm speaking against myself as a surgeon, talking about surgery not being a cure, but in all honesty, the big population-based contributions will be when we find a biomarker that gives us a diagnosis that we can go to a health fund or to Medicare and say, this person does have lipedema, this person doesn't have lipedema, and be definitive. Because, of course, the health funds and Medicare are worried that without a diagnostic, you will get people coming in who are claiming to have the disease, and they are then stuck because they have to offer treatment and they can't disprove definitively. And I kind of get that, and that's why we're so relentless in our pursuit of biomarkers to get a diagnosis, to find out who has got disease recurrence, say after surgery. If you can find the daughter or niece of an affected patient and you have a therapy, that's amazing. You can actually prevent it ever happening. And so that's where I think the really exciting part is. And we hope that, with the funding that's come from the Lipedema Foundation, Lipedema Australia, Stafford Fox and O'Brien Foundations for our research, as well as individual donations from patients. Of course, we now really believe that we will, in our career span, be able to be a part of something that hopefully makes this disease a footnote in history, that we look back on the paintings of Rubens and the sort of African tribal paintings, and we look back as a historic thing, because this disease, when treated molecularly, no longer exists. And surgeons, like with cardiology, surgeons had a role in doing all these cardiac bypass, but most of it's managed now through prevention, medicine, management of cholesterol, management of weight, management of diet, diabetes, stenting. Almost none of it's done through surgery, real extreme cases. And I hope that one day lipedema will fit into that narrative in a parallel.
That sounds like the best goal ever, and I am really keen for that to happen. And I hope that it happens in my, with lifetime too, when I'm young enough to benefit from those findings.
Fingers crossed.
So when you're talking about that workup of patients and how it's not just like the solution is not just surgery, and you spoke about what I believe you're talking about was conservative management.
Yeah.
So what I believe you're talking about is conservative management, and your
Yeah.
thoughts on conservative management and like it's anti-inflammatory diet, compression wear, consistent compression wear, and manual lymphatic drainage. Is that your understanding of the best conservative management?
Yeah, look, I think that every patient's different actually. So when patients ask about what is the best diet, there is no one diet. So for some people, keto works. For some people, paleo works. For some people, just portion restriction works. And importantly, for some people, the other diets not only aren't helpful, they're harmful. They seem to be harmful. They say there was worsening of my pain. So I say to people, you're an individual. You need to find out a dietary regime that works for you, that is sustainable, importantly, and that is something that has a foundation in what you're seeing. We know that inflammation is definitely involved here. So anti-inflammatory diets seem to make sense. If you have some dietary element that isn't really considered to be inflammatory, but in fact you notice that every time you consume that element, you get inflammatory exacerbation or pain, well, stop doing it. That's logic, right? So everyone's different, and I guess the recipe book is not the same. It's not a cookie cutter, but the principles are the same. Find the diet that's good for you. Find garments that are good for you. Some people tell me compression doesn't work, but swimming acts as compression. It seems that the water pressure helps me. So great, do that. That's a cheap way of getting that compression, a painless way of getting that compression. Manual lymphatic drainage, pumps. I mean, patients sometimes are blessed because they're near a therapist, sometimes they're remote. So can they learn remotely how to do the best manual drainage for them? I spend a lot of time mapping out people's lymphatics for them, knowing that they're not going to be candidates for surgery or they don't want surgery. But through mapping out the lymphatics, you can actually get the best regime. They can see where it collects and what time of day, and they can then use that to guide their own personal manual drainage. Obviously better if you have someone else doing it for you, but everyone can do something to help themselves. I think that's the message.
Yeah, and I think the more we reiterate that message to our community, it gives us our power back. Like as a patient, we are not helpless
100%.
in this disease. We can
100%.
actually do things that, and if we do them
it's
consistently,
a partnership, Tiana.
Yeah, I agree. We need to be involved in our own care and take responsibility for our own care, I suppose, as well, and find that relationship with our care providers that we create that trust. And it sounds like you do a really great job with your patients to try and get to not the root cause, because there's lots of variables, as you mentioned, like it's social and the dogma and the stigmas and also their like presentation. But at least we have people like you that listen to us and acknowledge how we're feeling, because it's quite lonely here sometimes.
Well, yeah, thank you. Look, it is one of those things that some of the stories you hear from patients, individual accounts of life events that have resulted from this are kind of, well, they're really heartbreaking actually, and they're not fair because, why did I get this and why did my sister Jackie not get this, or why? And I can't answer those questions at the moment. We're trying to do it. All I can say is that for you, the individual, we'll try and get the best solution that works for you to get where you need to be, as long as you're invested in it, as you say. And it's, it's something that we're trying to do. Ultimately, yes, aesthetics, as we said, coming back to that concept, but really what we're trying to do is to restore that individual's health to what it would have been if they didn't have lipedema, so that they can live out their full life expectancy. If you're wheelchair bound by 55 or 60, obviously there's a whole host of things that come on that are going to make it difficult for you to reach your full expectancy. Now, if we can just claw that back, we help people to fulfill their natural genetic destiny, then that's the big picture. It's not a leg or a limb or body image or whatever. It's actually trying to help them to, in the same way that managing diabetes and cardiac disease and these other imperatives are national priorities, we should have more attention paid to, I actually think there's a business case that would save a lot of money if you look at the secondary problems, how expensive it is to treat those, cellulitis and all the medical problems that result. Well, if you actually could put some money into research or treatment of the primary disease earlier than in the disease, then you would certainly be able to make a case that you're saving money that could be reinvested into the system in either grassroots preventative stuff, education, or research.
And that earlier piece, getting it earlier, is difficult because you can't really see it on face value, which is why the research is so important. Because if you can find those genetics that are turned on and why,
exactly,
then the diagnosis is much easier. You don't have to see it, I suppose. Yeah, great, very important work.
Yeah, absolutely. You can get the daughter of a patient who's suffering from it and spare them those years of suffering.
Yes, agreed. Now, I've hijacked this entire interview, so I'm going to let Shell ask a question now.
Go ahead.
Thank you so much. This has been an amazing chat. So much information. So we wanted to ask you, how was the World Congress? Did you learn something new? What was it like having all of these passionate people in one place?
Great question. It was so exciting that you came up to a place and you didn't have to explain to people what lipedema is. And of course, there are a lot of people who we've worked with, collaborated with, who we know. Obviously, we've met before. Stanley Roxon, Karen Herbst. We've been collaborating for years with them, almost 12 years now. And there were people we've been corresponding with or read articles by, or they gave us, feedback on our papers and things, who we hadn't met. It was really exciting to connect with them. So I think overall it was just a great atmosphere of collaboration. There were actual lipedema sufferers present and involved. And there was everyone from, their respective countries who were trying to break the back of this condition, pulling in the same direction with no sort of negative, doubting, sort of naysaying. It was just everyone was pulling in the same direction. We're working on a consensus piece now on sort of diagnostics and protocols, and there's a lot of collaborations coming out of it across. I mean, we commenced or sort of facilitated scientific collaborations with people from 7 or 8 different countries, and so of course that's how we maximise the funding that's available, is by not reinventing the wheel. So some of our genetics, we're doing collaborative work with people all around the world, and it was just great to be a part of it. In terms of what did I learn? I think I'm talking mainly about the science side of it now. Sometimes you're working in an adjacent area in science and in research, and someone else has been working in the adjacent area, and you connect those dots together, and it's like bang, revelation. It's fantastic. So that was happening, and it was just great to see that from, what did I say, it was 2013, 14, I couldn't find anyone to talk to about this, to sitting presenting sessions to 500 people in the audience, and listening to speakers and patients from all around the world. It was just like a sort of a dream come true, really. Like, there's not many fields, Shelley. There's not many fields that you can actually see it from the early stages evolving so much, and that's I think that's probably the most exciting thing.
That is exciting, and not to have to explain it. That would have been different for you. Instead of always having to say what lipedema is, you're in this place where everybody is have got the same understanding and the same, we're all working together. And like what Tiana and I have found, like listening to warriors and listening to their stories is so empowering to all of us, just to get those different accounts of what living with lipedema looks like, because it is so different. It is all so different.
Absolutely.
Yeah.
No,
So,
it's a privilege. Look, I say to patients, look, it's just a privilege to be an outsider, being along for the ride, and hopefully making a small contribution somewhere to helping people to realise what they have been denied all this time, which is just the ability to live a normal, comfortable, dignified life. That's ultimately what it's about. And yeah, it's a great journey, and it's not over, guys. We're just beginning. So thank you for your work as well, and thanks for this great podcast, and for beating the drum and raising awareness. Wonderful.
thank you for your support. Where can our community find you?
So I guess from the point of view of clinical practice, I work in a couple of clinical practices in Melbourne. One is Brighton Plastic Surgery, which you can just Google, and the other is East Melbourne Plastic Surgery. So we're just the hospitals we work at at St Vincent's Private, East Melbourne, Epworth Freemasons, and Holmesglen Private, with some at Cabrini, Brighton. And so there's a range of hospitals, and the two practices, you can just Google the numbers or ring. Any advice or there's a team of people willing to just have a chat and understand if we can help. In terms of the research side of things, the institute that I became director of in 2015, the O'Brien Institute, has now been folded into St Vincent's Institute, parent organisation. St Vincent's Health Australia saw fit to rationalise some of the institutes, and it's been a great win for us because we were an organisation of 30 people, and I literally had to raise all the funding to make the place run with our own hands. We still raise the funding, but in addition to that, we have capacity far greater than what we would have been able to afford, such as a commercialisation team, IP, HR. These things have become more and more important for any organisation, as you know. And now, SVI with a 200 person workforce incorporates all of those things, finance and all of those things that are really necessary. But when you're a research organisation that's lean and just trying to afford to be able to do the research, there's no way you can employ people and culture and finance and security and IT and all the things you need in order. So by rationalising us in, we still have to raise the same money, but the scope of our organisation has become so much more that we feel that that's really helped us accelerate to the next level in terms of research capacity, because we are able to then tap into a bigger pool of expertise and so forth. So that's St Vincent's Institute. You can Google that too.
Fantastic. Thank you for that. We asked some of our community if they had any questions for you. And one of the questions was about your wait list to get surgeries. And I'm being cheeky because, like I mentioned to you before, I'm incredibly impatient. So knowing that you have quite a wait list, I would be very anxious to get seen by you. But for the purposes of this podcast, I wanted to remind our community that the fact that you also do the research and you're the director of this institute, you're spreading yourself very thin there, Ramin.
Yeah, look, it's a really good question. I mean, we are, one of the things that happened in COVID was that we were able to, we had to, especially here in Melbourne, where we had the most draconian lockdown laws on the planet for a time. We had to adapt to that and largely did that through telehealth. So now that we've actually kept the telehealth part of things, and in a way, that's actually helped democratise, because if you live, there are patients who live in East Melbourne, they walk down the street to East Melbourne Plastic Surgery or Brighton or whatever, but there are also patients who, and 50% of the patients come from interstate. So that would mean a flight, accommodation, transfers, all that stuff. That's expensive. And if you do it 2 or 3 times, but through telehealth, we're able to rationalise that, which means we've actually been able to drop that wait list quite markedly. The other thing that's happened is I think we've become better at identifying, certainly, understanding those processes. So there are some people who now will come on and they'll now say to me, yeah, I reckon I've got 2 years of preparation here. And it's funny, I'll say to them 2 years of preparation, go, yeah, that's what I thought. So that alignment is happening. Equally, there are patients who come and they're completely ready. And so they can actually be seen and treated much more effectively because the people who need to wait have been able to push it out. The other thing is we are getting a team together to be able to triage people much more effectively, so we can reduce that time between referral to being seen or being assessed. So that's something we're currently working on, which I'll let you know more about when it's complete, but that's pretty exciting. So I don't think it'll be a case of everyone just waits a period of time. You would wait if you need to do something that will get you a better result. The other thing that's changed, which is interesting, is that the paradigm shift due to these new drugs like Ozempic and Mounjaro has meant that people can actually achieve degrees of weight control they couldn't do before. And oftentimes before it was saying, now that's not necessary for everyone, right? But for the people who can access it and can do it, there is an option that didn't exist 5 years ago or 6 years ago. And what that has meant is there are some patients who were never able to, because they were stuck in the vicious cycle, to get to a point where they get a fantastic result. It was just about doing what you can and just trying to get a little improvement. But now there is the possibility that those people, they might have knee disease, hip disease, joint disease elsewhere. They can now mobilize after they've done that weight loss, take control again and just break the cycle with some of those drugs. So I say to people, routinely I would say you do your dietary stuff. Sometimes people have given up as well. They just say, look, it's too hard. But you give them a date and a focus and a goal, and they'll say, okay, well, I can now focus my portion control, doing all those little things that we all know we should do much of the time, but just sometimes we just say, what the hell, it's Christmas. But if you have a focus, sometimes just a distinct period of time with the right motivation, not in a sort of a blaming way or sort of a failure way if it's not achieved. But if you give someone a period of time where they can really focus get their ducks in a row, focus the family, it's a team effort, etc., etc. 3 months off in trial, you'll find that they did manage to make a dent that they couldn't make before. And sometimes we'll say, okay, after 3 months, then let's go for one of these other medications and see what happens. And so it's a staged approach. So you need that time. It's actually preferable to have time. It's like a slow cooked meal, right? You go to an Italian restaurant versus a fast food joint. You've got the slow cooked meal. You've got the ingredients have been in there. They've been, reducing it on the flame, slow cooked. You get a better dish at the end with your recipe. If you just throw all the ingredients in a pot, they might be exactly the same ingredients. It's not going to taste so good. So time and slow cooking and evolution of a team and a relationship is also some of the key ingredients that help with getting an excellent result for the patient.
It sure does take a team, doesn't it? It's crazy.
Takes a village,
yeah. Yeah. Well, thank you so much. We have got so much incredible information from you. Thank you for taking the time to join us this evening.
My pleasure. I'll give you the double thumbs up again because it gives this effect.
That is so cool.
I can't, it doesn't work for me.
Computer?
If anybody's watching us on YouTube or Spotify video, I don't have the magic, but Ramin does. So well done.
Maybe it's only guest magic.
Maybe.
Host magic.
What a shame.
Well, so I've kind of taken more of your time, and I'm sure Tara will talk to you about a lot of this stuff when she does. But look, thank you for. I mean, obviously your questions indicate just how much thought and preparation you guys put into this, and how much you all represent the people who listen to you and watch you, and just keep it up, because everyone who makes a contribution like this is just moving the dial that little bit. And as one of my old bosses says, to get across an ocean takes a bazillion oar strokes, and each little oar stroke is important. And hopefully, if we all put one in, then we get to the other side.
Oh, I love that analogy. I'm a sucker for analogies. I love that one. That is good. And will we see you at the Lipoedema Australia conference in June?
Yeah, it's a good question. So I'm always there. I have been invited by the Canadian Plastic Surgery Society and the North American groups to be their guest at their society meeting. There is a chance that I might pre-record my talks if I can't get back, because it will be the week preceding. But Tara will definitely be there. She's one of the keynote speakers with Karen Herbst, and she will represent obviously our work, and I'll zoom in from wherever I happen to be. You never know. Like even if I was in Melbourne, I might have got COVID the day before. Who knows? So we can do things with technology now which we couldn't do before, and I'll be there not only in spirit, I'll be there in person or electronically for sure.
Oh,
Awesome.
Fabulous. We can't wait to either see you in person or listen to you. So thank you again for joining us this evening.
My absolute pleasure, guys.
Bye. Stay on the
Have a
line.
great night.
When we started the Lipoedema podcast, we relied on word of mouth and existing connections.
Our following has happened organically, and we are so honoured by your support.
As we learn more about the world of social media and algorithms, we have a request.
When you are listening to our podcast or watching on YouTube, let us know what you think.
Hit follow or subscribe.
Leave us a comment or write a review.
The more engagement we get, the more our message is shared.
And the greater our reach to those women suffering in silence.
Thank you for listening to the Lipoedema podcast. Lipoedema and its symptoms vary from individual to individual. The opinions and advice voiced in this podcast are of a personal nature and used for educational purposes.
Please take away from this podcast what resonates with you, and please see your GP or preferred specialist for diagnosis and healthcare. We are Shelley and Tiana from the Lipoedema podcast. Until our next episode, bye for now.